Peppercorn online for the questions how the representative for the occupied Palestine territory. He's available only in the first half hour, so we'll get to that. But if we have questions in the beginning, would be good to take those first. Otherwise, we'll have other colleagues for that here in the room as well. We'll have a special guest as well, as we had the Mpox Emergency Committee yesterday, but I'll leave that to Dr. Tedros to introduce. Over to you, Dr. Tedros.
Thank you, Christian. Good morning, good afternoon, and good evening. More than a year ago, I declared a public health emergency of international concern over the spread of Mpox in Africa on the advice of an emergency committee convened under the international health regulations. Since then, the emergency committee has met every 3 months to evaluate the outbreak. Yesterday, they met again and advised me that in its view, the situation no longer represents an international health emergency. I have accepted that advice. This decision is based on sustained declines in cases and deaths in the Democratic Republic of the Congo and in other affected countries, including Burundi, Sierra Leone, and Uganda. We also have a better understanding of the drivers of transmission, the risk factors for severity, and the most affected countries have developed a sustained response capacity. Of course, lifting the emergency declaration does not mean the threat is over, nor that our response will stop. And we note the Africa CDC's decision yesterday that Mpox remains a continental emergency. The possibility of continued flare-ups and new outbreaks remains, requiring adequate surveillance and response capacity. Ongoing efforts are needed to protect the most vulnerable groups, particularly young children and people living with HIV. WHO, Africa CDC, and other partners have maintained a coordinated emergency response, supporting countries to reduce transmission, address stigma, and expand access to testing, care, and vaccination. Nearly 6 million vaccines have been pledged. More than 3 million doses have been delivered to 12 countries, and just under 1 million doses have been administered. So we have made much progress, but we still face significant challenges. Mpox clades continue to circulate. Surveillance and access to diagnostics remains patchy. Response capacities are under strain from limited funding, and community engagement requires sustained investment and local partner coordination. WHO and our partners are working to mitigate these risks and sustain support to countries. However, financial resources are still very much needed to support this work. Standing recommendations for Mpox have been extended for another year until August 2026 to support member states worldwide. I have also extended emergency use listing for Mpox vaccines and diagnostics. To say more, I'm honored to welcome the chair of the Emergency Committee, Professor Dimi Ogoina from the Niger Delta University in Nigeria. Professor Ogoina, you have the floor. Can you please unmute your audio? We can't hear you.
Okay, can you hear me now?
Yes, thank you.
Okay. Thank you very much, the DG and the other members of the WHO Secretariat, partners, the media, and other guests. Good day to everybody. I think it's appropriate to first appreciate the DG and the WHO for the leadership and commitment to addressing global health challenges including the Mpox outbreak, which was declared a public health emergency of international concern in August 2024. On behalf of the committee, I think it's also important to appreciate the DG and the WHO for the opportunity given to all of us to contribute to addressing the problem of Mpox. The emergency committee had its 5th meeting yesterday, Thursday, the 4th of September, 2025. 11 of 16 members and 2 advisors were in attendance. Members listened to a presentation from the WHO Secretariat from most affected state parties and other countries outside Africa. They presented, gave an outline on the trajectory of the Mpox outbreak over time from the August 2024 to date, and the trends in cases, in mortality, and the response capacity. The key findings from that presentation include some positive trends which have been echoed by the DG. There has been a sustained decline in the number of cases of Mpox in the African continent overall, and also in the most affected countries of Uganda, DRC, Sierra Leone, and Burundi. There's also been a remarkable decline in the case fatality rate that has been observed in the DRC in endemic regions from 3.6% to about 1% over the period of 1 year. We have also noticed some remarkable increase in the testing capacity, especially in the overall, it has increased from about 30% to over 60%. In the DRC, it's still 54%, which is, of course, we know is very, very suboptimal. In many of the countries have improved their ability to diagnose and case finding, search for Mpox, and also there has been local investment from the ministries and government in the Mpox response. However, there are some concerns that were observed from the presentation and members. The first was related to the high case of fatality amongst people living with HIV/AIDS, especially in Uganda and Sierra Leone. Also observed was the tendency towards higher morbidity and mortality amongst infants and young children in parts of DRC, especially in endemic regions in the DRC. Of course, it's encouraging that Clade 1B that was thought to be a challenge has been exported to many countries, but has not resulted to sustained community transmission, and also not resulted to significant case fatality, with the case fatality less than 1%. Of concern to the members of the committee is the need to sustain the benefits and the gains of the declaration of the public health emergency, which has resulted to increase the political commitment, increase mobilization of resources, and also increase in response strategy to the Mpox outbreak. Having looked at the presentation from the WHO Secretariat, the presentation from the state parties, and the data available, and the criteria used for determining the public health emergency of international concern, the committee resolved to advise the DG of the WHO to terminate the public health emergency of international concern and to transit to a more coordinated, proactive, short and long-term strategy to address the challenge of Mpox globally and in Africa. The committee observed that Mpox remains a public health concern globally and especially in Africa. And there is need for us not to be complacent about the response strategy and not throw away what we have gained from the declaration of the public health emergency. The committee recommended the termination of public health emergency because it no longer fulfilled the criteria for declaration of public health emergency as indicated in international health regulations in 2005. But Mpox remains a public health concern, especially in Africa, and that there is need for a proactive, urgent support for the African continent. There is need for solidarity and partnership to ensure we address the gray areas, we improve response, improve diagnosis, surveillance, availability of vaccines, because currently vaccines being available to the African continent is still limited, and deployment of vaccines is hindered by logistic and financial challenges. The committee ultimately resolved that there's need for global solidarity in the response to Mpox, and there's need for continued investment, and also to improve on the successes that have been achieved from the declaration of the public health emergency. And the committee also noted that failure of the globe and stakeholders to continue to invest in the Mpox response will put the world at the risk of a resurgence of an Mpox outbreak, and there is need for vigilance and continuous support. Thank you very much.
Thank you so much, Professor Ogoina, for your leadership of the Emergency Committee over the past year and for your ongoing commitment to the fight against Mpox in Africa. Thank you so much. Of course, Mpox is only one of many health threats in the Democratic Republic of the Congo. Yesterday, the government of the DRC declared an outbreak of Ebola virus disease in the central province of Kasai. So far, 28 suspected cases and 16 deaths have been reported, including 4 health workers. WHO already has staff on the ground in Kasai, with more on the way. We're joining rapid response teams to trace contacts and find cases. We're collecting and testing samples, and we're providing technical expertise in surveillance, infection prevention and control, treatment, risk communication, and more. WHO has also delivered personal protective equipment, laboratory equipment, medical supplies, and a mobile lab. We had previously pre-positioned 2,000 doses of Ebola vaccine in Kinshasa, which we're releasing to vaccinate contacts and health workers. This is the 16th outbreak of Ebola in the DRC, and the government has rich experience from those previous outbreaks. I thank the government for its leadership in responding to this outbreak and for its transparency in rapidly declaring the outbreak and sharing the viral sequence. To fund the response, WHO has released $500,000 from our contingency fund for emergencies, and we appeal to donors to support the response. Now to Gaza. Over the past week, parts of Gaza have come under heavy bombardment as part of Israel's military incursion. If this continues, it could lead to an even worse humanitarian disaster, endangering water and sanitation facilities for nearly 1 million people, many of whom are already facing extreme food deprivation. As you know, famine was declared in parts of Gaza 2 weeks ago. Since the conflict began in October 2023, at least 370 people have died from malnutrition in Gaza, including more than 300 just in the past 2 months. And where hunger goes, disease follows. Lack of food and clean water and cramped living conditions are leaving people with weakened immune systems exposed to more disease. In the past months, more than 100 cases of Guillain-Barré syndrome have been reported, with 11 deaths, a syndrome that can occur after other infection and lead to paralysis. WHO is doing the best we can to alleviate suffering and evacuate those who need urgent medical care outside Gaza. Since October 2023, WHO has supported the evacuation of over 7,640 patients, including 5,300 children and 2,660 companions. But there are still more than 15,000 patients in Gaza who need urgent specialized care, including 3,800 children. More than 700 people have died while waiting for medical evacuation, including almost 140 children. However, the urgent problem we face is that too few countries are willing to receive them. We call for countries to open their arms to these critically ill patients. And we call on Israel to allow people to be treated in the West Bank and East Jerusalem where hospitals closer to home can take many patients. Above all, we call on the government of Israel to end this inhumane war. If it will not, I call on its allies to use their influence to stop it. The most intolerable part of this man-made disaster is that it could be stopped right now. People are starving to death while the food that could save them sits on tracks a short distance away. And for what? The starvation of the people of Gaza will not make Israel safer, nor will it facilitate the release of the hostages. This is a catastrophe that Israel could have prevented and could stop at any time. Starvation of civilians as a method of war is a war crime that can never be tolerated. Doing so in one conflict risks legitimizing its use in future conflicts. While the wars in Gaza and Ukraine continue to make headlines, the war in Sudan continues to be the war the world forgot. Like Gaza, Sudan is also facing a hunger crisis with famine conditions confirmed in parts of the country. This year alone, over 770,000 children are expected to suffer from severe acute malnutrition. WHO is supporting 142 centers that have treated more than 20,000 severely malnourished children so far this year. At the same time, the country is facing a severe cholera outbreak, which has spread to all 18 states with more than 105,000 cases and 2,600 deaths. In August, WHO supported vaccination campaigns that reached 3.5 million people. And we will soon launch another campaign targeting almost 2 million people in Darfur. Since November 2023, over 17 million people have been reached with oral cholera vaccines. The situation is especially severe in the region of North Darfur, where the city of El Fasher has been under siege for more than 500 days. More than 260,000 people need urgent health assistance. 35 health facilities have been destroyed. There are 5,000 suspected cholera cases and 98 deaths. 130,000 children are suffering from malnutrition. And survivors of sexual and gender-based violence need urgent care, including mental health support. UN humanitarian aid, including WHO supplies, hasn't reached the city in over a year. We call for the immediate opening of safe, unimpeded humanitarian access to El Fasher to meet the mounting health needs and save lives. We call on the RSF to lift the siege, and we call on all parties to the conflict to end the war. Finally, today, WHO is releasing the latest editions of the WHO model lists of essential medicines and essential medicines for children. These lists are among WHO's most important products, used in over 150 countries to shape public sector procurement, the supply of medicines, health insurance, and reimbursement schemes. The updated lists include new treatments for various types of cancer and for diabetes with associated conditions such as obesity. Medicines for cystic fibrosis, psoriasis, hemophilia, and blood-related disorders are among the other conditions. And finally, today is the last press conference for WHO's Director of Communications, our friend and colleague, Ghebreyesus, who is retiring after more than 6 years at WHO. Gabi has led WHO's communications through an incredible period in the organization's history, including the COVID-19 pandemic. She has done so with incredible dedication, energy, insight, empathy, and experience. Gabi, thank you so much for everything you have done and for who you are. Thank you for your outstanding commitment and contribution to WHO, and more importantly, to the people we serve. We will miss you, and we wish you every success for the next chapter of your life and career. Christian, back to you.
Well, thank you very much, Dr. Tedros. Thank you, Professor Goina, and thank you, Gabi. Yeah, with this, we open the floor for questions. Please, again, raise your hand with the raise your hand icon and unmute yourself when it's your time to speak. I'll try to see if we can get one question through to Rick Pippercorn. I was told he might have to leave, but let me see if he's still online. So we have one question from the colleagues of BBC. Doctors in Gaza are talking about the spread of an undiagnosed virus. What do we know about it? What are the symptoms? How dangerous is it? Over to you, Rick.
Yes. Yeah, just coming back from Gaza last Monday, I was there again for more than 2 weeks. There's definitely an increase in acute respiratory infections, but we, I think, are constantly reporting on the various diseases. We've seen currently an increase in acute respiratory infections, and slight decrease, for example, in diarrheal diseases and in jaundice. This has not been linked. There was a lot of discussions about COVID. There was a lot of other discussions, etc. That has not been confirmed at all. I just want to make that very much as the first point. What we, of course, see currently in Gaza, in this environment, and it was described also by the DG, in an environment of malnutrition, and in some places even worse, with horrific conditions when you talk about water and sanitation and shelter. I constantly see this wave. People are much more prone to definitely all the waterborne diseases, but also respiratory infections. Also, people are incredibly crowded. You look at Gaza now, more than 86% is incredible. The small Gaza, more than 86% is now what we call a militarized zone. So these 2.1 people, they are actually clustered in Gaza City in the north, and then mainly in the center and the west part, because as we heard also the DG, this military incursion is already hitting very hard on the east side of Gaza City. And then the central area, Deir Bala and Mawasi. So currently nothing confirmed. COVID definitely not confirmed. We definitely also struggle, and that's including in what was mentioned as Guillain-Barré syndrome. We struggle, and the health service struggle, with the lack of proper laboratories, especially lab supplies and everything related to that. So if we get more details, we will inform you on this. Over to you.
Thank you so much, Rick. Next question goes to Nina Larsen from AFP. Nina, please go ahead and unmute.
Thank you very much for taking my question. I wanted to ask about the situation in the US and how concerned you guys are about the situation at the CDC. There was a letter from all of the CDC directors going back to the Carter administration, warning about the health risks that the current Secretary of Health is putting Americans at, especially when it comes to vaccine access. There's also the Florida decision to remove the vaccine mandate there. So I was just hoping that you could say a little bit about what you think about what's been happening at the CDC. Thank you very much.
Thank you, Nina. We'll go to Dr. Kate O'Brien, Director, Immunization, Vaccines, and Biologicals.
Thanks so much for the question. I think the most important thing that we should make sure that we're focusing on is, first of all, the CDC in the US is an incredibly strong institution with many excellent, outstanding, world-class scientists, and WHO has had a long-standing collaboration, and the world has benefited from the expertise that sits within the CDC. And I'm sure that that expertise will continue. I think where we also want to address your question is on the question of vaccine mandates, and this is a topic that comes up not infrequently. I think it's important to remember that there are many aspects of our public health life where governments and institutions do have policies that help the public stay safe. Seatbelts, using corrective lenses for those who are driving vehicles, and the issue of assuring that vaccines are provided to all people who need vaccines is an important one. And there are many different policies that are used to enable and assure that vaccines are accessible. What is most important is that vaccines start and stop with trust. And without trust, there really isn't a vaccine program. And the second most important thing is the strong evidence base on which decisions about vaccines and the safety of vaccines and their impact are made. And the third is that vaccines are fully and in an unfettered way available and accessible to all people who need them. And so many countries have used policies that are called vaccine mandates that sometimes are misinterpreted as being sort of compulsory vaccines, and very few such countries have something called a compulsory vaccine. But vaccine mandates are very common in the data that is shared with WHO on an annual basis. In this past year, about 104 countries do say that they do have policies or laws that relate to requiring, encouraging children to attend school or childcare. So this is something that's very common. And we do recommend a context-specific approach to mandates. It's not the preferred way to assure vaccination because, of course, individual choice is the most fundamental part about what people are doing. But we have to be sure that the programs of immunization are providing a way for vaccines to be easily and readily accessible. And as I mentioned before, the public having accurate information, evidence on which they are confident that the programs are well crafted and bounded on safety and impact is the absolute most fundamental part. Many of the diseases, we have to remember, are deadly diseases. That's why we vaccinate. And so particularly for schools, which are environments where transmission, the mixing of children and kids are in classrooms and on playgrounds, it's really important that those kids are safe from what are deadly diseases. And that's the reason, the whole underpinning of why vaccines are so important. So although there are many different ways that vaccine programs can be encouraged and parents have access to vaccines that is not constrained by time, place, insurance status, very common for there to be policies that are around vaccine mandates. And the evidence does show that these can be effective. They can be the means by which children who aren't vaccinated are identified when they're registering for school. And as long as vaccines are then made available to them, this can increase coverage as well. In other settings, they're not very helpful. And so I really just want to come back to the context of the trust issue and the community issue. So it's very, very context specific. Thank you.
Thank you very much, Dr. O'Brien. Dr. Van Kerkhoff, you want to add?
Yeah, thanks. I just wanted to comment on the first part of that question because I think it's such a critical one and the importance of US CDC as a technical agency, the importance of national centers for disease controls or public health agencies are really critical in every single country, but the world needs a strong US CDC. We have continued to work with CDC throughout, from a technical partnership, sharing information about what is happening, working with many of their experts across many disease-specific areas. That technical exchange continues, but it is really important that national governments, all national governments, have strong evidence-based institutions. And I won't go into what Kate talked about with the vaccines, but of course wholeheartedly agree, but it covers the entire spectrum of prevention, control, readiness, and response. So I think, we just want to make sure we continue to support all scientists, public health professionals around the world to ensure that they have the best evidence to make the best decisions. That's what we do here, but also to call on that expertise. We're very grateful for our colleagues at US CDC and the hard work that they do, as with other national institutes and public health agencies around the world.
Thank you very much, both. Next question goes to Elaine Fletcher from Health Policy Watch. Elaine, please go ahead and unmute.
Hi, thank you for taking my question. This is about the new EML. I have two questions, actually. One is about the insulin. You mentioned insulin analog as being something new in the table of medications. However, there were insulin analogs also approved, as I recall, in 2021 and 2023. So I just wondered if you could be a little more clear about if there's a new type of insulin analog that's been approved this time, and if so, what? And then in terms of also cancer drugs, I noticed that you have some new drugs for colorectal, cervical, and lung cancer, but I don't see any new breast cancer drugs there in the list. And I know that's been an issue in the past as well, sometimes because of the costs associated with those drugs. So just if you could comment on those two aspects of the listing. Thank you.
Thank you very much. Elaine, between Deus and Lorenzo, who wants to start?
Okay, I will start. Thank you very much for the question. In terms of insulin, indeed, you're right. We have had various types of insulin on the essential medicines list. We have had long-acting insulins and also medium-acting insulins, both human and recently analogs. What has been added to that to complete the whole range of treatment is the short-acting insulins. And this is also to make sure that all the ranges of conditions and that we have the treatment package to cover all the conditions that we need. And often these are complementary, and those where conditions is appropriate to use long-acting insulin, but also we need to also have conditions where we need short-acting. So what has been added is the short-acting, in addition to what has been in place as long-acting and intermediate acting. On the issue of cancer drugs, specifically, and after that I'll ask Lorenzo to specifically talk about breast cancer, but also let me say that the current edition of the EML has added a number of new drugs, including cancer drugs. And we know the incidence, especially of non-communicable disease, is increasing, but throughout the world, not only in the high-income countries, but also in low and medium-income countries. We also are lucky that recently highly active cancer medicines have become available. What is true that some of these new cancer medicines are costly and expensive. And the essential medicines tool, essential medicine list is one tool that is used by WHO and member states to catalyze or enable other interventions that will stimulate access. Things like pooled procurement, reimbursements, generic or biosimilar manufacturing, and the technology transfer. This is a prioritization tool. So it is a tool WHO that is putting there, first of all, to ensure access, but also to bridge that gap between the high-income countries where, because these expensive new medicines have been expensive, but we would like to have universal access. And we use the essential medicines list to enable these tools of access so that they can become affordable and accessible to all member states. I pass over to Lorenzo to tackle the breast cancer specific question. Thank you.
Thanks, Tadeusz. So this year, like at EML, the expert committee did evaluate 25 cancers, right, across 7 different applications. And clearly also breast cancer was involved. But the expert committee had like a clear logic supporting the choice. First was starting with measuring the efficacy of the immunomodulators in each of the cancer, right? Then looking to the affordability and price, and then also seeing what were the strategies to increase the affordability. And among these 25 cancers, the lung cancer, cervical cancer, and colorectal cancer were prioritized, as in these patients we had the larger effect. The WHO adopts now a threshold in recognizing then the cancer medicines that have merit to be listed, that is to prolong at least survival by 4 to 6 months, that is to filtering down the number of medicines that arrive on the market, and this threshold has been applied then to all. In some cases, the trials, like the trials in breast cancer women, are still maturing. So is the follow-up of these patients is not yet consolidated. And that is also in this case, the expert committee had a preference for those results in which we have long-term follow-up data, and we are sure about the effect on overall survival and quality of life. Thanks. Over to you, Christian.
Thank you very much, both. And we'll move on to the next question, and it's Priti Patnaik from Geneva Health Files. Priti, go ahead.
Hi, good afternoon. Thank you for taking my question. I wanted to understand today's decision on the Mpox. How will you ensure that the attention continues to remain on preparedness and also a response for basically potential future outbreaks? Does this mean that the attention will go away, and how would you basically ensure that necessary research and development and sharing of technologies, for example, will continue despite sort of today's outcome of today's meeting? Thank you.
We'll start with
Chairman. Okay.
Oh, yeah, of course, Professor Unger.
Okay, thank you very much for that question. I think that observation came up during our discussion at the emergency committee. And one thing we need to recognize is that the evidence before us shows that Mpox is still a public health concern, especially for a number of African countries. What we observed was some level of stability and downward trend in the most affected countries. There are a few countries that are witnessing a form of resurgence of number of cases. Of course, there has been improving capacity to respond, improving testing capacity, and improving surveillance and community engagement. But there's still a lot to be done. And it was our view that what needs to be done can be done outside the emergency phase. So what is important is that while we are removing the emergency, we need to keep the urgency. because Mpox remains a public health concern, and there is need to continue and sustain the investment and even increase the investment in the Mpox response. So we all collectively agree that there is need for more advocacy, awareness creation, and emphasis that Mpox remains a public health concern. This is not a time for us to reduce the investments in terms of financial investment, partnership, solidarity, especially for most affected countries in the African continent. And so that responsibility is a collective responsibility of various stakeholders, the affected countries, but especially resource-rich countries and other stakeholders that have the resources to support response. One critical point that was raised in our meeting is to say that although we have noticed some improvement in the response to Mpox, if we lose our guards, if we do not sustain the investments and the successes, there's likely to be a resurgence. So that's the key message. We must sustain what we are doing and continue the benefits of the declaration of a public health emergency of international concern. Thank you.
Thank you very much, Professor, and Dr. Chikwe.
Yeah, thank you very much, Priti, for the question. Like Professor Goyna, who just spoke, and really thanks to Professor Goyna and the Emergency Committee for the excellent advice they continue to give us and the world on the response. We learn every day from the emergence of this virus. When it re-emerged on the African continent in 2017, very little was known about it. We had to learn very quickly. That knowledge has since expanded. This is the second fake that is being de-escalated. It doesn't mean that the virus has disappeared, and it doesn't mean that we will relax our efforts at all. In fact, we will intensify our efforts because the work is now defined for us in the long term. To continue learning about this virus, continue improving the tools we have around surveillance, diagnostics, treatment options. And really, if there's one bright spot out of all this, is the capacity that have increased across many countries on the African continent as they have responded to this. And if you look at the trajectory of the outbreak in the last country where we had a fairly big outbreak in Sierra Leone, you would see that the containment of cases after it escalated initially around 3 months ago was really remarkable. And so I think despite the situation at the moment, we have a sustained increase in capacity to detect and respond across the continent. And we're fairly confident in working with our national public health agencies, ministries of health, research institutes, working with global partners that have supported access to vaccines, equitable distribution of access according to need across the continent, that we will continue to drive forward the challenges and opportunities that we've had to improve the response. So this is actually not an indication to de-escalate, but actually an indication to sustain our efforts and make sure we continue to contain this new disease that re-emerged on our continent a few years ago. Maria, I don't know if you want to add to that in terms of what we're doing moving forward.
Thanks very much, Chikwe, and thanks very much for the question. No, to really re-emphasize what's been stated by the chair and by Chikwe here. This isn't about saying that Mpox isn't a problem. It isn't saying that Mpox has gone away. We expect continued circulation. We expect there to be flare-ups in other countries. But as the chair has pointed out, as DG has pointed out, as Chikwe has pointed out, capacities continue to increase. And the ability of our national counterparts, our local partners across diagnostics, across community engagement, clinical care, safe and scalable clinical care around infection prevention and control has increased. Of course, there's a lot more work that needs to be done. There's more work that needs to be done for early diagnosis, early clinical care, ensuring that vaccines are used appropriately to protect populations who are most vulnerable, those who have immunocompromised HIV populations, the youngest of children. So for us, this is a really important message that lifting of the public health emergency of international concern doesn't mean that the problem has gone away. There isn't a lot of investment that is necessary, including not only the technical capacities, but financial investment as well. We haven't raised funding for Mpox with the last SPRP. And of course, this message might sound like, the problem has gone away, but as DG has pointed out, it has not. And countries are working very hard, and you've heard about concurrent outbreaks, now Ebola. So there's a lot of challenges that these countries are facing. So we need our partners, we need funders, we need governments to continue the solid investments in Mpox and in fact to increase those, because what we do for one infectious disease is also helpful for others. So it's adding on those and continuing to build those capacities.
Thank you all very much for this. And we have one more from Amy Maxman from Nature. Amy, please go ahead and unmute.
Hi, thank you so much for this conference. I was just wondering, the response to outbreaks, specifically Ebola outbreaks, is super expensive. And I'm just wondering, what is the impact of the withdrawal of the US from the WHO? Have the membership fees already, I assume the US isn't contributing anymore. How are you financially?
Thank you very much, Amy. We'll go to Dr. Chikwe Ikwazu, the head of the emergency program.
Hi, Amy. Thanks for that, and great to hear your voice again. I think if we reflect on the Ebola outbreak going on at the moment, I think the most important thing, I think that we can all be a little bit happy with globally is really the response of the colleagues locally, the speed of their action, the ability to connect the dots. Once they had a fairly small cluster of cases and a number of deaths, how quickly they alerted their own national public health agency, how quickly that agency put the resources together, alerted WHO, the time it took us to get to the field, get the samples to the lab, get it tested, have a sequence out and published today. I mean, yes, a lot of resources are required, but the experience in DRC really shows that investment in local capacity, investment in building institutions and country capacity around the world will ultimately actually reduce the need for resources globally from one single donor for a couple of big sources to continue to support the work that we do. Having said all of that, there's no doubt that we will continue to need the resources to respond. And, you know, the only way we can do this sustainably into the future is through sustainable financing of WHO. So, yes, the financial situation we are in challenges all of us, but our work goes on. Our primary response has been as good as it can be. And the challenge on all of us now is to sustain the response over the next few weeks. I did make sure that we are as quick as possible to define the extent of the outbreak, which is really the primary objectives over the next few days, and then sustain the outbreak to make sure that we don't end up in an unfortunate situation. But I'm fairly confident that with all the efforts happening already, that we'll get ahead of this. Abdi, maybe you can say a few words on just the intensity of the response over the last few days and the work we've been doing with the colleagues locally.
Thanks, Chikwe. I think you have covered most of it. In terms of our work in WHO and the leadership of the government, we have been supporting them in deploying a multi-response team, to all of team. But the logistic challenge, the team left on Wednesday and they just reached today morning. It's just how difficult it is. But despite that challenge in having the result there within and then population is incredible and remarkable. And as you rightly said, the investment that have gone to the country, that's the only way sustainable. But we really require the health system, as Dr. Tedros talked about, Mpox and all this, the vulnerable, that investment going to Gavi, to PEPFAR is the health system required. While DRC has a lot of experience, be it in Tanzania, in Rwanda, the withdrawal of that has affected the whole health system. Sampling transport was a major challenge. So the investment done by the countries, I think they will, but the sudden withdrawal has created a shock. Not the country will not be able to allocate resources. We have seen every other country coming in, but the sudden withdrawal without notice has impacted. And by the end of the day, it's the global community that's going to lose. So from WHO side, we are very confident that under the leadership of the government, that this outbreak will be able to control. We request more. We have the contingency fund, as DG said, $500 million. And Amy, you are right. Ebola response in a very difficult logistic can expand millions of dollars from $300 million to $800 million. We don't believe we may need that because of the rapid response from the government and the leadership, but the location it is in the southwest and neighboring province and neighboring country, this can also turn up to a large outbreak. We don't anticipate that because of the timely interventions, but I want to agree with you, this is an investment. It may look more, but it's an investment in the global security that requires every country, where the US, UK, neighboring country in Africa, to come together in solidarity to support DRC, because what they have done is incredible. That transparency, I don't think we have ever seen, and I want to give credit again to that team. Collect that sample and publish it immediately and declare the outbreak without fear, because they are confident what they were able to achieve.
Thanks so much, Paul, for these clarifications. We came to the end of the questions, but we have Dr. Rick Peppercorn from the, oh, pardon, did I lose somebody? Oh, sorry, Dr. Janet Diaz, of course, on the Ebola question.
I also just want to, I'm not going to repeat what my colleagues have said, but also give a big congratulations to the INRB and the Ministry of Health for their rapid action. And of course, the interventions that are ongoing now at the field level, the importance of the local teams in establishing their treatment center, making isolation centers, taking care of those patients, setting up a referral systems, all of these things, doing the basics well, which had to start. And now with the surge teams that are going in, and it's not just dependency on one group, it's a collective action with partners. And I also wanted to acknowledge all the partners that are contributing to this, and everyone together with their resources, with their assets coming together to deliver on what the Ministry of Health is trying to accomplish. So I think this is where we are in the phase right now, is really getting the partners together, working under the leadership of the ministry to establish safe care, to establish ensure that the vaccine delivery gets done in a timely way, and to advance and hopefully stop this outbreak as soon as we can.
Thank you so much, Janet, for that important addition. Now we come to Dr. Rick Peppercorn, our representative in the occupied Palestinian territory, to add on the respiratory disease which we are targeting before.
Yes, thank you, Christian. Just 3 points. One, it is specific to reported acute respiratory infections cases. They increased, with morbidity rising from 58 to 62% among reportable diseases. So it's increased with as much as people say, no COVID cases were confirmed. And meanwhile, I think the acute watery diarrhea declined from 42 to 35%. We also, of course, check another thing. One new AFP case was reported, and in total in 25, that was already 49 cases. A total of 1,075 suspect meningitis cases were reported between May and August. 73% were classified in viral meningitis and 27% as bacterial meningitis. And since June 2025, a total of 103 suspected Guillain-Barré syndrome cases were reported, with 11 associated deaths. Serum samples, 20 of that has been dispatched. There's an absolute lack that already raised on lab supplies related to that. I want to get back to one other point, which I think the DG pointed out about this plans for an ongoing military incursion in Gaza City. And of course, rightly it was said it would be another humanitarian disaster on the existing disaster. But just to point out what it would mean for health system, for the struggling health system. Currently, 11 out of the 18, what we call partially to minimum functional hospitals, are located within Gaza City. They account for 35% of total inpatient bed capacity in the Gaza Strip and 48% of all intensive care beds in the Gaza Strip. So if that goes away, if that falls away with it, can you imagine even the impact on the health system and the health sector? Last point on medevac, because DG stressed this so much, and rightly so. Just to look at the figures, that close to 7,700 patients have been medevaced. Massive achievement, but more than 15,000 patients are in need. People ask me often, is the system working? Currently, there's a priority list of over 8,000 patients ready. So more than 8,000 patients are waiting to be medevaced. And the key asks are again and again, we need many more countries to receive Gaza priority patients. We need to have the traditional referral pathway to the East Jerusalem Hospital in West Bank restored, and those hospitals also supported. And we need to support also the WHO and the WHO team here. We are ready to expand the medevac and also our OSL operations, but of course, we need flexible support for that. Over to you. Thank you very much.
Thank you very much, Rick. And let me ask Dr. Van Kerkhoff to add on the situation of the respiratory diseases in the region, maybe.
Yeah, thanks, Christian. So zooming out a little bit, just to add a little bit more context, and to say, you know, we're supporting to get more laboratory diagnostics in to support the country as well. But of course, these viruses are circulating. Respiratory viruses are circulating. COVID is not gone. It's not in the news anymore, but it is circulating. We are seeing increasing trends around the world for COVID circulation, but very few countries are actually reporting now. Flu is circulating as well. And if you have conditions where people are living in these horrible conditions, you have underlying conditions, you have malnutrition, you have starvation, outcomes are going to be worse. Rick outlined all of the diseases that are circulating there that are killing people, that are harming people. And of course, respiratory pathogens are there as well. So we will work and continue to support, and Nabil is sitting over here as well, to make sure that we provide additional diagnostic resources there. But of course, there are many, many immediate needs of the people of Gaza. But just wanted to contextualize this to state that these viruses are circulating around. And it's likely to be something that is common, but of course we will continue to work with the country to make sure that we identify. Thank you.
Thank you very much, both, and thank you very much all. We've come to the end of our press briefing, and I thank you for your participation, especially also Professor Goyna, the chair of the Mpox Emergency Committee. We'll be sending the audio files and Dr. Tedros' remarks soon after this briefing. And then for any follow-up questions, please come to us at mediainquiries@who.int. Now, let me see. Let me give to Dr. or Professor Goyna if he wants to add a few closing remarks from his side.
Yeah, thank you very much. I think just to say, I appreciate once again the WHO DG and his team for the work that's been done. As everybody has emphasized, we have competing health challenges across the globe, Mpox being one of them. And it's very important that we work collaboratively and collectively to ensure we address our public health challenges, including the challenge of Mpox. Thank you very much for the opportunity.
Thank you very much, Professor. And before we give now to Dr. Tedros for the closing remarks, let me ask our Director of Communications, Gabi Stern, to share a summary of her last years with us here. Thank you very much.
Thank you, Christian. Thank you, Dr. Tedros. Thanks to everyone for what you said about me today. And it really should be said about the communications staff at WHO in countries, regions, here at headquarters, but also our brilliant technical colleagues who have done massive communications over the years, including during the COVID pandemic, which obviously was a historic and also terribly difficult period for the world. I just wanted to say thanks to reporters online. I was one of you for many decades. In many ways, I'm still one of you. I think once you're a journalist, you're always a journalist. And I thank you for your coverage of all the health issues of WHO. And I encourage you to continue being fierce and telling the truth. We need you more than ever. So thank you, and back to you, Christian.
Thank you very much, Gabi. Now, over to Dr. Tedros.
Thank you, Gabi. Again, all the very best. You're an amazing human being, and we will miss you. But once WHO, always WHO. That you should know. Then to the members of press, thank you for joining us today, and see you next time.
Recording stopped.